In the UK and Europe and Africa, and good afternoon to India and Asia, and good evening to our friends in New Zealand. Welcome to the very first Global Neonatal Journal Club, brought to you by Mercy Perinatal in Melbourne, Australia. We're absolutely thrilled to have you all here. The numbers are climbing at the moment, and would you believe that we've had 940 people register for today from 83 different countries, which is just absolutely mind-blowing, and we're really very thrilled to have you all here. I'm Brett Manley. I'm a neonatologist in Melbourne, Australia, and your co-host for Global Neonatal Journal Club. And I'd like to introduce my amazing co-hosts, and then we'll talk about how today is going to run. So, Julie, would you like to introduce yourself?
Hi everyone, Julie. I'm a neonatologist now in the Mater, Brisbane. Very happy to be here. I'm not as millennial as Brett and Shiraz, so I didn't give a swanky video, but look forward to this new format of education. Thank you, Brett and Shiraz.
Thanks, Julie. Over to you, Shiraz.
Hi everyone, I'm Shiraz. I'm a neonatologist here at the Mercy in Melbourne and a postdoctoral researcher at Melbourne Children's Global Health.
Welcome, Shiraz. We're looking forward to working together over the next however many journal clubs there are. But we've also got a couple of very special expert guests with us today. So I'd now like to introduce Graham Polglaze and June Yi Kong. So Graham and June, if you want to turn your cameras on and wave to the crowd. Professor Graham Polglaze is from the Hudson Institute for Medical Research and from Monash University here in Melbourne, and he's a fetal and neonatal physiologist whose research focuses on understanding the physiological mechanisms of the transition at birth. So his input to today's studies is going to be fascinating. And to June, who's an adjunct assistant professor from the KK Women's and Children's Hospital in Singapore, and her research interests include neonatal resuscitation, and she's led several delivery room randomised trials and collaborated on many others. So welcome to you as well, June. So we can't wait for later on. We're going to be discussing these papers at length with our panel. This is a webinar, so for those of you listening in, you won't be able to ask your questions live on camera, but please do put them in the Q&A or the chat at any point during the webinar, and we'll get to as many as we possibly can after we've reviewed each paper. We think the session will go for probably a bit over an hour, and it sort of depends how many questions and things we've got and how much discussion we have. But get settled in, and we're going to head over to Shiraz now to review our first study, which is the ABC3 study. So over to you, Shiraz.
Thanks, Brett.
Oh, my apologies. Sorry, Shiraz, we were going to do this first, weren't we? I forgot about it. We mentioned earlier just how many countries we've had joining us. And here's a smattering of the countries, not all of the 83, obviously, but on the right-hand side, I think these are the ones that have got the most registrants from. So Australia, UK, India, Nigeria, Malaysia, New Zealand, United States. It's the middle of the night in the United States, so welcome if you're watching this. And then on the left-hand side, we've got some of the countries with fewer people joining, but that we're just so thrilled to see some African nations represented there as well. And these registrants come from all sorts of different disciplines, of course, neonatologists, but also our nursing staff, academics, paediatricians, midwives, sonographers, educators, and maternal child health nurses. So it's wonderful that the audience is so multidisciplinary as well. All right, Shiraz, now we're up to reviewing the ABC3 trial, so over to you.
All right, let's get straight into it. So this is the ABC3 trial published by Ronnie Knoll and colleagues from the Netherlands, and this was published in the LANCET Regional Health earlier this year. So in terms of a quick bit of background, delayed cord clamping for at least 60 seconds is widely accepted to improve preterm survival compared to the practice of routine immediate cord clamping. But there's two major disadvantages, we think, of delayed cord clamping. Firstly, not all babies are not all babies are able to receive the whole minute of delayed cord clamping, particularly the extreme preterm babies, because of the clinician's assessment that the baby needs immediate help breathing. And so somewhere between 50 and 80% of babies don't receive delayed cord clamping. And the second disadvantage is that this sort of time-based approach of saying, well, let's aim for 60 seconds or more, that sort of neglects the potential advantages of physiologically based cord clamping. And physiologically based cord clamping is the approach where cord clamping is delayed for as long as is needed until the lungs are aerated and the cardiopulmonary circulation is established. And in terms of experimental studies, physiologically based cord clamping has been shown to potentially have really useful hemodynamic benefits. And so the ABC studies 1 and 2 initially confirmed feasibility and safety. And this trial is the ABC3 trial, which was aiming to look at clinically important outcomes. And the comparator here really is the sort of now standard practice, which is delayed cord clamping alone of around 60 seconds. So we thought this trial was addressing a really topical and important question with the potential to impact long-term outcomes in a really high-risk group. So what did these researchers do? They conducted a parallel group, individually randomized superiority trial across all 9 Dutch tertiary referral centers. And they used electronic one-to-one allocation with random permitted blocks. And they stratified participants based on their gestational age, as well as the treatment center. The participants were preterm infants born before 30 weeks gestation with antenatal consent, and the exclusions were those that you typically see in trials of delayed cord clamping. But one I'd like to highlight is the exclusion of babies where there was a cesarean section planned within 15 minutes, and that was for logistical reasons. It would take time to set things up. The intervention was going to be respiratory support with an intact umbilical cord, which is really what's needed to achieve physiologically based cord clamping. And to achieve this, they had the Concord table, which is one of the platforms around, where the platform can be moved really close to where the baby is born, either at cesarean section or at vaginal births. That allowed the baby to have radiant warmth, a plastic wrap to be placed, as well as respiratory support commenced with a device that would provide positive inspiratory pressure as well as CPAP. And in this intervention, the cord was clamped only after certain criteria of cardiorespiratory stability were achieved. That is a heart rate of greater than 100 beats per minute, a good oxygen saturation level of above 85, and an FiO2 below 40%. The comparator, like I mentioned before, was delayed cord clamping without respiratory support, aiming for 30 to 60 seconds, which is what's practiced in many places, but of course not all. And the outcome defined in this study was a composite outcome. It was survival or survival without one of these comorbidities. And the comorbidities they picked were a major cerebral injury, defined as intraventricular hemorrhage of grade 2 or greater, or PVL, or the other comorbidity of necrotizing enterocolitis greater than or equal to stage 2. Importantly, outcome assessors were blinded to the treatment allocation because, of course, the researchers and clinical staff could not be blinded to the intervention. Now, the paper provides a helpful flow diagram accounting for all the participants. We felt that the sample was somewhat close to a representative sample. I've just highlighted here that about a quarter of potentially eligible women were not approached for consent. Another quarter or so where consent was not obtained, and the other quarter of potentially eligible participants actually timed out. They were born after 30 weeks gestation. So amongst the 2,600 or so eligible women, about 600 were randomized in the trial. The rest of the flow diagram is a bit complex, but I'll just sort of point out that that amongst the 600 or so infants randomized, the group that was allocated to physiologically based cord clamping on the right here, about 20% of those infants didn't receive the intervention because of the reasons outlined there. In particular, the need to go to an emergency cesarean section or not enough time to set up the intervention. Twins were handled in a way that represented the complexity of the intervention. Vaginal births with twins were both allocated to the same intervention, and at cesarean section, only the second twin was randomized in the trial. Now, who was actually in the trial? Let's look at Table 1. So Table 1 shows that most babies in this trial were actually between 26 to 29 weeks gestation, with a median of around 27 plus 5 weeks gestation. We thought that there was a relatively high proportion of babies with growth restriction, around 25%. Most preterm trials have about 10 to 15% of babies with growth restriction. And we thought it was interesting that about half of the babies were born by cesarean section. And in other similar settings, this proportion is often a little bit higher. Most babies received at least one dose of, most mothers received at least one dose of antenatal steroid. We thought that the groups were actually well balanced, but we would have liked to have seen some data on socioeconomic status and ethnicity. Okay, moving on to the primary outcome. So we've got very similar proportions of babies with the primary outcome of survival without major cerebral injury and or necrotizing enterocolitis. So 71% in the physiologically based cord clamping group versus 67% in the time-based cord clamping group, with an odds ratio of 1.18 and a p-value of 0.33. So no evidence of a difference in the primary outcome between the two intervention groups. And if we look at the individual components of that composite primary outcome, again, there was no evidence of a difference in any of those individual components. Now looking at this pre-specified subgroup analyses, so we mentioned gestational age as one of the strata. There appeared to be an interaction with sex. So in this sort of pre-specified analysis, there appeared to be higher survival without those comorbidities in the male infants receiving physiologically based cord clamping, 69.6%, versus those receiving time-based cord clamping, so 61.8%, with a p-value for interaction of 0.026. The potential benefit in male infants was primarily driven by a decrease in major cerebral injury. Moving on to secondary outcomes. So in the intervention group, the researchers really achieved quite a long duration of cord clamping. So the average time was over 5 minutes before the cord was clamped during physiologically based cord clamping, and just under a minute in the time-based cord clamping. And this is probably similar to what most centers would achieve who practice time-based cord clamping. In terms of the time to stabilization, that appeared to be quicker with physiologically based cord clamping, probably also corresponding with earlier commencement of respiratory support. The other secondary outcomes, there appeared to be fewer blood transfusions in the physiologically based cord clamping group. We see this consistently in trials of delayed cord clamping. The longer the duration of cord clamping, appears to be fewer transfusions. Interestingly, there appeared to be a lower proportion of babies who had late onset sepsis with physiologically based cord clamping, 27% versus 33%. And lower admission temperature with physiologically based cord clamping, 36.3 versus 36.7 degrees. Again, a consistent finding in trials of delayed cord clamping. In this study, the researchers actually somewhat uniquely looked at parental impression and thoughts of this approach. They report less anxiety and more content with the physiologically based cord clamping group. Really importantly, they reported safety outcomes. So maternal blood loss and postpartum hemorrhage really important with the 5+ minutes of delayed cord clamping. That appeared to be similar between the two groups. And surgical site infections, again, there's lots going on in the sterile field here. That appeared to be quite similar between the two groups. Now, important to note that there were, I counted 46 secondary outcomes, and the p-values were not multiplicity adjusted. So some of these findings could be purely due to chance. And then the authors go on to describe this learning curve effect. So this was an exploratory intention to treat analysis, suggesting that centers where the number of procedures of physiologically based cord clamping, so that's the x-axis here, centers that did many more procedures of physiologically based cord clamping, those centers seem to have a greater benefit in terms of physiologically based cord clamping compared to time-based cord clamping. So centers that were just sort of learning and getting into this new approach tended to not have the benefit compared to time-based cord clamping. Now, this is really intriguing. Hear a little bit more about it. It would have been nice to see the individual points of the 9 different centers to see how they sit along this regression line, to understand whether there's some clustering or whether there's one outlier that's pulling this line towards the top right. And also just to sort of reflect on the fact that this is an analysis that loses the advantages of randomization. So there could be differences in other practices amongst the different centers. For example, initial oxygen concentration that's used may have been different in the different centers. That may also influence this learning curve effect that's described. So, to summarize, we thought this was a robust trial, a multi-center trial with a really good sample size. This was the first preterm trial of physiologically based cord clamping that compared where the comparator group was standard time-based cord clamping, time-based delayed cord clamping, rather than immediate or early cord clamping. Of course, that meant that there was inclusion of infants needing resuscitation, and the study really confirmed the sort of feasibility as well as the safety aspects of this intervention, but did highlight that there's really a learning curve when it comes to implementing and potentially reaping the benefits of physiologically based cord clamping. There was comprehensive short-term outcome data and some really interesting data about parental perceptions. Limitations. We thought there was potentially some selection bias. There was the requirement for antenatal consent. It's tricky to get around, but it means that sometimes these trials where antenatal consent is required, there's a potential of recruiting a less sick and more prepared group of infants. In accordance with Dutch practice, no infants born between 24 weeks of gestation were included, so potentially the most vulnerable infants who may or may not have benefited from the intervention. And in terms of protocol adherence, we thought actually 80%, achieving 80% with the complexities of physiologically based cord clamping was really good, but not quite the 100%. So 1 in 5 babies didn't actually receive the intervention that was imagined. The experience of the different centers the lack of experience may have masked a larger effect or benefit of physiologically based cord clamping. And the secondary outcomes, got to sort of interpret those findings with caution because there were many secondary outcomes and there was no adjustment for multiplicity. There was, in terms of the parental survey responses, this was only really completed by about a third of parents, and parents of babies who died or didn't have or who had the major comorbidities were less likely to respond to the survey. So we cannot know whether the results would be similar if we had a fully representative sample of all the participants in the trial. So what does this all mean for us as clinicians? Practice in different places around the world is different. I know many centers in the UK perform intact cord resuscitation. And I think this trial justifies the approach of either continuing to provide intact cord resuscitation or time-based delayed cord clamping according to the local expertise and capabilities. We're eagerly looking out for the long-term results of this trial, as well as Vent First, which was the other recent big trial of intact cord resuscitation. And this trial really raises questions about sex differences in the benefits of physiologically based cord clamping. And I think as researchers, we need to think about how we get better at dealing with the heterogeneity amongst these extremely preterm babies. The findings around learning curve, potentially learning curve effects, really does highlight the importance of embedding implementation science into randomized trials, and that's really increasingly a call for building these sorts of additional perspectives into clinical trials. And finally, this trial really does contribute valuable data to inform future meta-analyses and international recommendations for cord clamping strategies for preterm babies. But overall, congratulations to the investigators. It was a really well conducted, informative randomized trial. Hence, we decided to include it in our journal club today. And now let's move on to hear from the lead author, Ronnie Knoll, who was interviewed last week by Brett Manley.
Hello, Ronnie. Fantastic to have you at our Global Neonatal Journal Club, the very first one, and your study and your paper is the first that we're looking at today. So it's really fantastic to have you, and thank you for your great work on the ABC3 trial.
Thank you very much, Brett. Thank you for the invitation. I'm really glad to be here. Thank you.
Well, Ronnie, you're a neonatologist in Rotterdam, where you've been for almost a couple of decades now. You trained in the Netherlands and in Belgium prior to that, and you've been very interested in these delivery room and cord clamping type studies and done a lot of collaboration with the team at Leiden in the Netherlands and a little bit also, of course, with our great physiologist in Melbourne, Graham Polglaze, is here today on the panel as well. So you're as the first author of the ABC3 trial, and you were telling me that's actually the subject of your PhD. So congratulations, and I hope you get awarded that very soon. You're obviously the right person to speak to about the results. So we'll kick straight on. Tell us a little bit about how the ABC3 trial came about. What led up to this trial and this design?
Yes, thank you. So it started all with the physiological experiments, I think, in Melbourne more than a decade ago, where we saw that if you stabilize preterm lambs, in that case, with intact umbilical cord, it might be better for the transition of the preterm lambs in that case. And so we tried to bring that to the clinic, and it was not really easy because it was not done before in the way we did it. So the first thing we had to do is have proper equipment. So at that point, we started to design a new resuscitation table to do the intact cord resuscitation at the bedside. There were some trials done before. The largest one was the cord trial in the UK, where they used standard resuscitation equipment, which was quite difficult, I think, if you read those papers. And of course, Anoop Kathira did it in California, also a trial with an equipment, but we thought it was not good enough. So that's when we designed the new resuscitation table, which we called the Concord. It was done in Leiden with the technical department in Leiden. And when we had the resuscitation table, we started the first trial. That was our ABC1, which was a feasibility one in preterm infants, in which we decreased gestational age during the trial and tried to do the procedure, which we thought was successful. And then we went on with ABC2, where we assessed the efficacy of what we did. So the question was whether we could stabilize the preterm infants as we could do in the way that we did it before. So in that trial, we included around 40 infants, and we thought it was good enough to proceed to the large clinical trial. So we showed feasibility. We showed that we could stabilize infants in a proper way. And then we proceeded to the ABC3 trial, which was a large clinical randomized trial.
And how did you,
so that was
in ABC3, how did you decide what the intervention and control group would be? What's the thinking that went into that?
Yeah, so we thought the control group would be the normal way of stabilizing infants at that point. So we did delayed cord clamping of 60 seconds in the control group, which was quite new because the trials before still did immediate cord clamping in the control group, which made it maybe a little bit different than the trials before us. And the intervention was PBCC, so we based it on the preclinical data, but also on the recordings we had from the delivery room. And we had to decide, of course, and we're going to discuss that probably, what PBCC would be in preterm infants. And there are different ways to define PBCC probably in literature now. But our approach was to use physiological data of the infants to define the moment the infant would be stable. And stable we defined as that the lungs had taken over the gas exchange function from the placenta. So you need lung aeration, you need pulmonary blood flow, and preferably you need spontaneous breathing. A lot of preterm infants reach spontaneous breathing in the first minutes of life, of course. Not maybe in the first 1 minute, but in the minutes after, definitely. So that was the goal, to use physiological parameters to define that the lung was functioning and had transitioned and the baby was stable. So that was our definition of cord clamping.
And you've so nicely articulated the long history of biological plausibility and the way that you've escalated how to study that leading up to the ABC3 trial. And of course, the neonatal community was very hopeful, really, that this would be a successful intervention that would improve outcomes for very preterm babies. This concept of physiological-based cord clamping or resuscitation on the cord, especially for the little babies, it made a lot of sense. But ultimately, there was no difference in the primary outcome, which was survival without major cerebral injury or necrotizing enterocolitis. And so, just to be provocative, because there's also been another couple of trials that have not shown significant improvements with these similar interventions. Is this the end of physiological-based cord clamping and resuscitation on the cord? Can we all just go back to doing things how we've always done them? Or is there a little bit more to these results?
Yeah, I think there's a lot more, of course. So I know the primary outcome was not statistically different in our trial, of course, but I think we can discuss a lot more. The first thing is probably to discuss the primary outcome. At the time, if you do a large clinical trial, it's not so easy to define what your primary outcome would be. So at the time we designed the trial, we thought, of course, it must be a combined primary outcome of mortality, which is important, of course, and IVH or cerebral damage, because in the delayed cord clamping trials that showed a difference between delayed cord clamping and immediate cord clamping. And also the Cochrane at that time showed possibly a difference for necrotizing enterocolitis in the preterm infants. So that's why we included those three outcomes in the combined primary outcome. So mortality, cerebral damage, and necrotizing enterocolitis.
So just on that, before you go on to other outcomes, if you did the ABC3 trial again, have you thought about, in retrospect, would you use a different primary outcome? And if so, what would it be?
Yeah, that's the goal, the key question probably.
Not an
so, no, that's really difficult, and we see that a lot in neonatal trials. I think if you do some intervention in your NICU, or in our case in the delivery room, is it possible to show results at the extent of mortality or longer term outcomes? And of course, those longer term outcomes and mortality are multifactorial, and it's difficult to have one intervention to show such a large result in your clinical outcomes. And I think we are not the first ones where the primary outcome is not statistically different between groups, but at the end, after more trials or after meta-analysis, it shows that it may be or it is an important intervention. So that is difficult for a single clinical trial, I think. And also, if you think about how many infants you need for showing your results, is quite difficult. So we estimated you will discuss that probably, we estimated our sample size to show a difference of 10% in the primary outcome. So showing a difference in 10% for mortality and cerebral damage is quite difficult probably, and ambitious probably. But if you aim for a smaller difference, which would be maybe more reasonable, then you need a lot of infants, and the trial is impossible to do, and you don't receive any funding for a trial if you say, well, we need 5,000 infants, and then the funders say, well, that's maybe not very realistic. So it's always difficult to balance.
Yeah, it's not easy to do big neonatal delivery room trials, I think is the message there.
Yeah.
You did find some interesting differences or hints of differences in some of the subgroups and secondary outcomes, which you were very careful to point out. We need to be careful in our interpretation of those, given that they're secondary and subgroup analyses. I did want to ask you specifically, though, about this concept of the learning curve in the last minute or two we've got together, because this is important. Firstly, I want to start that question by saying, were there times that you recognised through the trial where physiological-based cord clamping was unable to be performed or was not able to be done as per the protocol? What were some of the issues that came up with that?
Yeah, so that was in the trial. So there was basically, we had some, how do you say that? Sometimes it was difficult to do the PBCC, and it was also in the article, in the paper, because sometimes we were too late with the equipment and in the delivery room. So it's difficult to predict when a mother is giving birth. And sometimes the obstetricians say, well, it will take a while, and 2 minutes later, the baby is there. So there was one point in the trial which made it more difficult. And also the design of the trial was so that we didn't include emergency cesarean sections, and also in the beginning of the trial we did not include maternal anesthesia, general anesthesia. So if those infants were randomized, and that was the case, there was an emergency cesarean section, then we excluded the infant for PBCC. In real life, it might well be possible also to include these infants, because those may have the highest benefit of performing PBCC, but in the trial they were excluded. So those made it in the trial a little bit difficult, and we had to exclude some infants. But in real life, it may be possible. Yeah,
you needed.
So that's important for interpretation. Yeah.
Yeah, there was the antenatal consent as well that was required. That led
exactly
to that, and the other thing, of course, is the Netherlands is well known at the moment that you don't offer neonatal intensive care to the tiniest babies born before 24 weeks. So I know that changed over time, but they weren't included in this trial. So you really nicely talked about the learning curve, and one of the figures in the paper really demonstrates this amazingly, that as people do more of these procedures, the effect of the intervention becomes more positive. It seems like they get better at it and it has a better outcome. What is your message to all of the researchers out there trying to do clinical trials in the delivery room or trials of interventions? I think about, CPAP manoeuvres or intubation manoeuvres or cord clamping manoeuvres. This is something we all need to be mindful of, isn't it?
Yeah, so this might be the most important thing we learned from our trial. And we also, if we look back, we might have done things differently. So exactly what you tell is what we see. If you have more experience, then it looks like the primary outcome difference is larger. So we are deeping into the figures and doing secondary analysis on this topic, on the learning curve. So we are preparing a paper for that because it is an important message, maybe the most important one. And what we did is that we had two centers that participated in the trial, and two of the centers had experience before the ABC3 trial, and the other 8 centers did not have experience. So they started the procedure with the trial, and it might be that we have underestimated that it is probably wise to learn a procedure like PBCC before you start the trial. I think that is an important message if you're going to design or perform a new clinical trial in neonatology.
You need to do it on patients first before we even start the randomized trial.
Yeah, yeah, that is of course ethical complicated because you are probably not allowed to do that, but we have to figure out if we can find out some sort of way to have learning experience before you start a trial. Of course, everybody was trained and was trained with the procedure, was trained with the equipment before the trial was started, but still in real life, it's different than the training. So that might be an important factor in our trial. I think you are right. So we hope to show you some more in the next papers and secondary analysis that we do from the data we have of ABC3.
Well, thank you, Ronnie. We can't wait to see what comes next. We really appreciate your time today with our Global Neonatal Journal Club. It's been fascinating to hear directly from you and some of the insights from the trial, and we really appreciate your time.
Thank you very much, and I look forward to the meeting.
So over to me. Hi, everyone. And I think Ronnie is online as well. So Ronnie, if you've got anything, just type it in the chat pane to ask. We've got
Hello, Ronnie. Fantastic to...
Bye-bye, Brett.
My finger slipped.
No worries. Okay, so we've got a couple of questions on the chat pane, but we've got our panelists here, Graham and June. Let me, unmask you guys. Look, while Brett mulls over the open questions on the Q&A pane, maybe I could throw 2 questions, one to Graham and one to June. So the first one for Graham is from Dr. Dharma from Indonesia. So not many people have the Concorde trolley and all these fancy whiz-bang things that Ronnie and many of us use in the Western countries. What do you think of cord milking for this population?
Thanks very much, Julie. In response to that question, we know that umbilical cord milking is harmful for babies less than 28 weeks of gestation. It increases the risk of all and severe IVH. So current guidelines do not recommend umbilical cord milking in this population, particularly the extremely preterm infants. There isn't shown to be that harm in older infants. And again, that's likely due to lung aeration being a critical component of what drives IVH, and which is a potential confounder within the ABC3 study as well, not showing that outcome. So certainly we would not be recommending umbilical cord milking in infants less than 28 weeks gestation.
Thank you. So what would you advise for developing countries or low resource settings to reduce the risk of anemia, problems with direct cord clamping?
I think there's been some really fantastic studies done by the Leodell group, Heggie Erstell in particular, showing that, again, the most important aspect of physiological-based cord clamping is aeration of the lung prior to cord clamping. And whilst in ABC3 this was achieved through to the provision of respiratory support, it can actually be achieved by stimulating the baby to breathe, delaying cord clamping until after the infants have breathed. A NOOPS study and many other studies have shown that majority of babies will actually breathe independently within the first minute of life. So my strong recommendation is to be openly stimulating these babies, get them lungs aerated, get them breathing before we clamp the umbilical cord. I would also point out that Shiraz is online. That baby duck trial did not require the use of a fancy table like the Concord setup. So it is possible to do resuscitation on a mat on the mother's legs if that's necessary.
True, simple is best. Thank you, Graham. And I might go on to June now. Hi, June. Okay, this is a very, I guess, learning curve trial. You are very familiar with teaching resuscitation. How would you, if it showed a difference, how would you envisage that this could be incorporated into daily practice?
Yeah, so thanks, Julie. That's a great question. So for what we see in a graph, centers with more experience definitely showed better benefit or differences. I would think that how we can incorporate into real life setting is we need to make sure that we are equipped for it, make sure the infrastructure, you can have the equipment that you have, or you might have to modify. I'm just thinking in my head that this Concord table might not even fit in my delivery room in Singapore because we all know that it's so expensive, space is very limited. So we might have to tailor to the local needs. But as for the resuscitation team, I think lots and lots of simulation, potentially simulation runs in the space that you have before even trying to implement it, because if it's done in the wrong hands, it might actually cause more harm than benefit.
Absolutely. Thank you so much. Thank you to our panelists. We might have to move on to the next paper. Shiraz is answering the questions like crazy on the Q&A pane. So have a look if you type your questions in there. And we'll start with the second paper. Thank you.
Okay, I'm just going to pause for a second because I can't see the slides.
1 second, Shiraz. How's that, Shiraz?
Good to go. All right, let's get into it. Second trial. So this is the very exciting DOXY trial that was published last month in JAMA Pediatrics, led by Anup Katheria. Good. So in terms of a bit of background here, now we're sort of talking about FiO2, initial FiO2. What's the initial amount of oxygen that we should provide extremely preterm babies during when we commence respiratory support? The current recommendations are to use 21 to 30% and then titrate based on oxygen saturation data. But over the last few years, we've had this emerging data come through from observational studies or reanalyses of trial data sets, suggesting that if these extremely preterm babies don't hit that 5-minute target of an SpO2 of 80%, that seems to be independently associated with a composite outcome of death or severe intraventricular hemorrhage. And we've also had this recent net motion network meta-analysis come through in JAMA Pediatrics last year, which compared these different initial FiO2 strategies and found that a high initial FiO2 of 90 or 100% appeared to result in a lower mortality when compared with low FiO2 21 to 30%. And that is sort of feeding through to the international recommendations, which will be updated this year, to suggest that it is reasonable to begin respiratory support with 30% oxygen or more. But concerns about oxygen toxicity persist for these extremely preterm infants, and this question is really another aspect of resuscitation that's really topical and important. And the DOXY trial takes quite a unique approach to addressing to this idea of using a high initial FiO2, and that is combining oxygen with intact cord resuscitation. The hypothesis being that providing 100% oxygen during delayed cord clamping would reduce hypoxemia at 5 minutes, compared with commencing resuscitation with an intact cord, but using a lower FiO2 of 30%. And the sort of science behind of providing this oxygen with the umbilical cord intact is to do with the protection that the placenta and the placental circulation affords to this infant that's exposed to a high initial FiO2. So in this diagram here, the high FiO2 reaches the alveoli and will hopefully drive pulmonary vasodilation and drive that pulmonary circulation. But because we have ongoing venous return from the placenta with low PO2 blood, the systemic circulation on the right-hand side of that circle is protected from the high PO2 of the blood entering and becoming oxygenated at the alveolar level. So the placenta may well protect the systemic circulation from the effects of from systemic hyperoxia, and perhaps Graham might expand a little bit on alternative mechanisms by which the placenta might be protective. So the science is cool, and this study really is a pilot trial trying to evaluate whether a high initial FiO2 during delayed cord clamping might be beneficial. So how do they actually deliver this intervention? In ABC3, they use the Concord table, which is used frequently in many places in Europe. In this trial, they use the LifeStart platform, which I know is used widely in the UK, for example. It essentially, again, is a portable platform with a source of air and oxygen and a face mask to deliver positive inspiratory pressure and titration of oxygen. And this can be used again at cesarean sections and at vaginal births. What did the researchers do? Well, they conducted, like I say, pilot parallel arm randomized trials stratified by gestational age, under and above 26 weeks. And infants were assigned their randomized allocation just before birth by opening a sealed envelope. The participants were infants born between 22 and 28 plus 6 weeks at 3 medical centers in California, again with a requirement for antenatal consent. The exclusions were again similar to previous trials, but there was interestingly an exclusion of a rupture of membranes prior to 20 weeks gestation, so babies at risk of pulmonary hypoplasia. The intervention was intact cord respiratory support with 100% oxygen for a duration of 90 seconds after birth. So commence at about 30 seconds and then ongoing until about 90 seconds. And the researchers here in these centers are familiar with using a colorimetric CO2 detector to identify when the babies need some positive pressure ventilation to aerate those lungs. After cord clamping, in the intervention group, the oxygen was abruptly weaned to 30%, and then followed usual care of titration based on oxygen saturation levels. The comparator group here was not delayed cord clamping, time-based cord clamping, as we saw in ABC3. It was, in fact, intact cord resuscitation, but with a lower FiO2 of 30%. And so the trial is really trying to differentiate between the effect of the oxygen in the two arms. The primary outcome for this pilot trial was a physiological outcome, so the proportion of infants who achieved oxygen saturation of 80% by 5 minutes after birth. We thought that was a clear question, well designed. The primary outcome was realistic for this trial, but it's not necessarily the perfect surrogate of longer term outcomes that we care about. We thought it was interesting that there wasn't an upper bound. The target of above 80% could include 100%, and do we necessarily want that in terms of hyperoxemia? And some of those observational studies that I mentioned sort of point out that the predictive value of not reaching an SpO2 of 80% is strengthened by also having an outcome relating to bradycardia. So infants who don't reach their oxygen saturation targets and have 2 minutes of bradycardia, those are the ones really at risk of the death or IVH composite outcome. Good. So moving on to our flow diagram, again, really comprehensive, accounting for all participants. I found it a little bit difficult to get a good sense of the generalizability here, but we had 140 infants randomized amongst from the 670 that were assessed for eligibility, and the primary outcome was available for all infants. On the right-hand side of that flow diagram, you'll see that 5 out of the 72 infants randomized to the 30% oxygen group didn't receive the intervention due to a short umbilical cord. So who was recruited in the trial? We had babies who were mostly around 26 weeks gestation, who again had around 15% growth restriction. Most babies had a dose of antenatal steroid. And we did think there were potentially some chance imbalances between the two groups, quite common for smaller trials. The proportion with the proportion who had twin births were a little bit lower in the high oxygen group, and fewer cesarean sections again in the high oxygen group. Moving on to the primary outcome. So the authors found that amongst the high oxygen group, 69% overall achieved their target oxygen saturations of at least 80%, compared with 39% in the low oxygen group. And this was an odds ratio of 3.74 with a 95% confidence interval of 1.8 to 7.8. And the authors also present this as an adjusted risk difference of about 30%. So a 30% higher risk or probability of achieving that saturation target. Most of that benefit appeared to be in the larger stratum. So the third line there, showing the babies between 26 and 28 plus 6 weeks, where 85% of the babies achieved the oxygen saturation of 80% by 5 minutes. That should be 85 rather than 51% in the paper, and that's a typo that we've highlighted to Anoop. Okay, good. So moving on to the secondary outcomes. The time to achieve oxygen saturations of 80% was higher in the high oxygen group, so the intervention appears to have worked in terms of getting those saturation numbers up more quickly. But interestingly, when we looked at the sort of indirect markers of spontaneous breathing. And really here we're hoping that the better oxygen saturations stimulate spontaneous breathing in the baby. Those markers, for example, positive pressure ventilation or intubation, were quite similar between the two groups. And finally, just to highlight the outcome from near-infrared spectroscopy, so regional cerebral saturation, a marker of systemic hyperoxia, that was similar between the two groups. So the STO2 there highlighted around 81% in each group, but that was in a subset of babies at one center. In terms of clinical outcomes, there were some tantalizing potential benefits in the high oxygen group in terms of PDA requiring treatment and grade 2 to 3 BPD. But of course, these are secondary outcomes, two of many secondary outcomes that were shown. All right, so in terms of the strengths, this was a double-blinded 3-center RCT. I failed to highlight the fact that the oxygen blender was actually blinded. So the clinicians and staff didn't know what the intervention was, and nor did the outcome assessors. It's really the first clinical trial to investigate the safety and efficacy of using 100% oxygen during 90 seconds of delayed cord clamping. Protocol adherence was really high. Only 4% of infants didn't actually receive the assigned treatment. There's no loss to follow-up. And the short-term safety data appeared to be quite reassuring. Limitations. Again, this is a relatively small study, so in terms of the less common adverse events and longer-term morbidities, the trial is really not powered to look at differences in those outcomes. We eagerly await data on oxidative stress. That data is part of this trial, and wait for those outcomes. And there was potentially an imbalance in some of the baseline characteristics, as I showed in Table 1, that may have favored the doxy group, which is not uncommon in smaller trials. Important to just reflect on the fact that the comparator group wasn't, plain old time-based delayed cord clamping. It was intact cord resuscitation. And so we cannot really know whether the 100% oxygen during delayed cord clamping is the critical thing that's driving the higher saturation. The higher saturations at 5 minutes may still be achieved by commencing respiratory support after clamping of the umbilical cord. And as I alluded to before, the saturation of 80% is probably a reasonable short-term outcome for this pilot trial. But there are questions about that, I think, particularly with some of the studies coming through with Torpedo 3060 that Julie led, that despite potentially achieving better saturations, it may or may not translate to better clinical outcomes. So what does this all mean for us at the cot side? If we are a center that provides intact cord resuscitation for preterm infants, it's reasonable to consider a higher initial FiO2, closer or indeed 100% oxygen versus 30%, and extending that duration of cord clamping to 90 seconds. But this trial really does need to move on to a big randomized trial, and it's up to us to get behind Anup and the team when that trial does in fact get up and start recruiting. Important again for us to consider the challenges to real-world implementation. These trials are often carefully controlled, lots of support to actually get the intervention to work. But what happens in terms of real-world implementation in diverse settings where things need to be tailored to individual contexts, and it's worth considering that for each of our participants today. That's all from me. I think just summarizing this trial, a really great, innovative RCT, and we await the next steps. All right, let's move on and hear from Anup from the interview with Brett.
Thrilled to have Associate Professor Anup Kathiria here with us, joining us at our first ever Global Neonatal Journal Club. So welcome, Anup.
Thank you, Brett. I'm really happy and honored to be part of your first journal club. That's great.
We've just been reviewing your DOXY trial, and we'll get to that in a second. But firstly, I'll just quickly introduce that you're an Associate Professor of Paediatrics and the Director of Neonatal Research at the Sharp Mary Birch Hospital for Women and Newborns in San Diego. So thanks so much for joining us at a slightly awkward hour for you before you start call. You're well known to the neonatal research community. Many of us would have seen you speak about your many trials in cord clamping, also early caffeine, and also, you know, we love talking about innovative trial designs and outcomes, so we might get to that as well. So thanks so much. Shiraz has already done a review of the DOXY paper, so we'll be able to dive right in. But just before I forget, we're also thrilled to be having you in Melbourne coming up in November at Cool Topics in Neonatology. So if you want to see Anoop speak live, he's a very dynamic speaker. Come along. All right. Well, as I said, we've already reviewed the trial. Tell us a little bit about how you arrived at this trial and this trial design for the DOXY trial. What had come before?
Yeah, no, I think it's a great perspective and sort of where I've gone with cord clamping trials. You know, when I first even started tackling the question of what to do with the cord, I always wanted something that was simple that I knew most obstetricians were willing to do. And that's where, you know, even the whole idea of cord milking, which again isn't the topic today, but a lot of my early trials were focused on, you know, if you could give the cord a couple of squeezes, then you get the baby handed off and it all is fine and well. And I was actually really averse to intact cord resuscitation because it took a lot of effort to coordinate. And I knew people were doing it, but it was always going to be challenging to sort of set up equipment and sort of move that way. As you know, cord milking didn't really work out for the tiny babies. It ended up causing more IVH, and we ended up having to essentially stop that practice universally. Nobody milks cords in babies under 28 weeks. But one of the challenges I've always struggled with delayed cord clamping, and I saw this even in our cord milking trial, was that babies that receive delayed cord clamping of a minute or even longer without any support actually have more lower oxygen saturations compared to, for instance, term babies who get delayed cord clamping that actually oxygenate better. And so we noticed that even in our own data with cord milking compared to delayed cord clamping, that at 5 minutes, 2/3 of these babies had lower oxygen saturations. And you may say, well, okay, maybe that's okay. Maybe those babies are fine. But we were seeing a number of trials of delayed cord clamping that babies were still not having all these benefits we thought we'd see. As you know, the Australian placental transfusion trial fortunately reduced death as one of its many different secondary outcomes, but didn't have an effect on IVH. Many of these other things we thought we'd see, we did not. So part of me, and even anecdotally, when I would go to deliveries, I'd see babies be vigorous, come out at 23, 24 weeks, but by the time they got to a minute and then were handed off to the warmer for us to resuscitate, oftentimes were apneic and needed more resuscitation. So I got in the idea of, let's try giving them CPAP and ventilating them. This was before some of the studies that I know have already been mentioned, like the ABC3 trial. We said, let's give these babies CPAP. And this was about almost 10 years ago, in 2015. I started with low oxygen. Let's try air, even 30%. And we did a trial where we compared giving support versus nothing. And lo and behold, there was no difference, no benefit at all. And, we monitored oxygen saturations, mean airway pressure, looked at BPD, IVH, hemoglobins, nothing. And so I sort of, you know, a couple of years ago thought, well, if we could give them more oxygen, maybe they'll saturate better. It sort of makes sense. And then there were other studies coming out that sort of validated that idea. So one of them, and you've probably heard them present before, and they were part of the ABC3 trial, was the group in Leiden looked at babies that were getting 100% versus just 30%, all after the cord was clamped and cut. But what they showed was that oxygen, it's almost like a stimulant, like caffeine would be. As soon as you gave these babies 100% oxygen, they immediately would start to breathe better. They showed better tidal volumes on respiratory function monitoring, better transition in the delivery room. And so the idea of, could you adopt this to the cord, where we know that during delayed cord clamping, better breathing, better lung aeration leads to better sort of placental transfusion and efficiency of delayed cord clamping. We wanted to see if we could apply that. And, you know, before we even did our first pilot, and Brett, you know this well because you write lots of grants, you sort of need a pilot of a pilot. Before you tell the reviewers, hey, I want to study 100 plus babies to do a larger RCT, they want to even see, have you even tried this on a few kids? And so we got permission from families to even try 60%, 100%. And we didn't really see the bump until we gave them about 100% or so of oxygen. And the 90-second piece that we came up with was just realizing in my first trial that by the time you deliver the baby, put CPAP on the baby, dry them off, and get them situated, you've already lost 30 seconds. So we wanted to give them at least a full minute of oxygen just to get that baby to sort of jumpstart and start breathing. And so that was the premise of, well, why'd you pick 90 seconds? Well, we needed a minute of delayed cord clamping. And the 100% was basically the highest we could go to get these babies to start oxygenating better.
So you chose saturations at 5 minutes is the outcome that you've chosen, or the proportion of infants that reached 80% or higher. How important is that? And talk a little that as an outcome and predictive of other outcomes, perhaps, but also, why you had to go with that rather than, the traditional longer-term clinical outcomes we're seeing in big trials. Tell us a bit about the balance there.
Yeah, I know it's a great question. And again, it's great to talk to someone like you that has done so much work in clinical trials. And you understand that, when you're picking a pilot and you want to pick something that's very short-term from the intervention, but that could be predictive of other outcomes. And so I know one of your panelists, Julie Weiss, is going to be sort of reviewing this as far as the Q&A, but her work early on, looking at data from her own torpedo trial and other studies of oxygen, demonstrated that if babies did not achieve an 80% saturation by 5 minutes of life, they're more likely to die or have severe IVH. And we, even using our own data in San Diego, tried to replicate that. We looked at babies in 5 of my older cord clamping trials and said, well, do these babies, that don't achieve this saturation, irrespective of the FiO2 we gave them, because one of the advantages we had that these trials didn't is we were able to look at the FiO2 for these infants. And we saw that by 3 to 4 minutes, the team is trying to give them more oxygen. And by 10 minutes, they're okay. But at 5 minutes, if they're still hypoxic, they ended up having more IVH and dying. We showed the same thing. So we knew that this is and I really think, Brett, this is almost the new 5-minute APGAR. It's much more objective rather than sort of looking at how a baby's moving around and their cry and breathing. It does really predict how infants are doing. So even though it wasn't an exact science, we know that every baby that has a low sat at 5 minutes doesn't bleed and die. We said if we could achieve that, it was a better surrogate than looking at something like IVH and BPD. And again, this is why I refer to you. You know better than anyone. If a pilot, and we've had pilots show, giving caffeine and Lisa BPD. Well, we're not going to use a pilot of 100 babies to say this is the intervention. It could easily be a spurious result. We wanted to focus on something that made biological sense. And if some of your secondaries end up achieving trends or significance, that's fine. But we know pilots can go either way. You could easily see an opposite effect when you do a larger trial. And so we didn't want to power a 140 baby study on something like a clinical outcome when we knew that wasn't going to be enough data.
That's really important to point out. APGAR scores, we could talk about that for a while as well. We'll leave that for another day. But what about people that say, well, how do we know this is safe? So I know you'll acknowledge that we can't be absolutely sure that, this is safe in the longer term and all the rest, but giving high FiO2s to newborn babies, we're very worried about it in the NICU with retinopathy and other problems. Right. How did you convince yourself that you needed to try 100%? And can we be at least partially sure that this is a safe thing to do in those first minutes when the baby's on the cord?
Absolutely. No, I think it's a great point, Brett. 100 baby study plus is not going to be enough to say definitively it's safe. But I think what you're getting at is that, yes, you want to be able to look at a lot of biomarkers, better physiology than you would be able to. So we do have additional papers coming out. One is a sub-study where we looked at, glutathione reductase levels at cord blood. So seeing actually the oxygen, how is it affecting the cord blood in the baby? And then again, at an hour of life to show that, in fact, we're not seeing this drop in antioxidant levels when you're giving 100% oxygen, which is always a concern. We did look at NIRS, another measure of cerebral hyperoxia, and then looking at sort of how many babies were in and out of ranges using, Jennifer Dawson's textbook curves, where they satting 98%, which could be a marker of hyperoxia in the Dell room, versus 95. And our trial results, which are published there, show that these babies are within range from that early hyperoxia. And then, like you said, you look at things like ROP, which were not different in this group. BPD, which was actually lower, again, in our pilot, suggesting that we're not seeing this lung injury that people might be worried about with that level. And then another point for the listeners is that, we oftentimes worry about a brief exposure of 100%. But oftentimes, if you look at the delivery room data, we do many times give these babies short, bumps of oxygen. Or even when you go to intubate a baby in the NICU, for instance, you'll give them this brief exposure. And most of us aren't worried, oh my goodness, we're actually causing this baby to get ROP from this exposure. But the real thing, Brett, is that by giving this during delayed cord clamping, you're allowing that benefit of that placental blood that's flowing into the baby as a huge sink to sort of suck up all this additional oxygen, this free radicals, by the fact that you have a lot more antioxidants in the blood that are circulating continuously between the baby and the mother. And I think that's what we're hoping to show in sort of subsequent studies. And I'm excited to know that there actually were some great abstracts presented at the PAS meeting by Graham Puglisi's group and Stuart Hooper that are going to sort of hopefully turn into papers that people can read to show some of these effects of having the baby, or in a case of a lamb that isn't experiencing systemic hyperoxia during delayed clamping or physiological based cord clamping.
Well, that's fascinating, Anoop. And in this journal club, we've already talked about ABC3, and Julie's one of our hosts and panelists here, and she led the Torpedo 3060 trial. The Torpedo 3060 trial was 30% versus 60% as an initial FiO2 for extremely preterm babies, and found no difference in the primary outcome of death or brain injury, although they did show nicely a trend to higher saturations in the first few minutes with the 60% oxygen. And Julie's presented those results at PAS this year, although that trial remains unpublished. We've got the Torpedo trial with higher oxygen. We've got the ABC3 and other trials of resuscitation on the cord, like Vent First. And so far, no one's come up with a really positive result like we've all been hoping. I think particularly we thought that there might be great advantages to resuscitation on the cord and physiological-based cord clamping. So where's your mind at now with all of this evidence coming at you and results coming at you? Where do we sit now, and what's next?
Right. I think it's a great question, because I was hopeful for this as well, that intact cord resuscitation would be better. You allow the sickest babies to get, deferred cord clamping, which is always a struggle. The trials, Vent First and ABC3, as you know, even though not explicitly stated, talking to those PIs, the centers pretty much started at 30%, with, exception of Leiden that switched in between in the trial. So you were seeing low oxygen during deferred cord clamping, even if it was at different durations in these studies. So, our hope is that, we're applying for a larger multi-center trial of 1,000 babies to see if we can actually replicate DOXY, but powered for clinical outcomes, as you mentioned. But I think, how do you take in the studies like Julie's trial, which was post-cord clamping, and looked at these two different FiO2s? So you could either say, well, 60 and 30 are equivalent, maybe they're both safe and there's no harm, but then you're still asking the question, is there an advantage of going higher, or is there an advantage of giving these babies more? And I think that's what we need to think about, is what to do post-cord management. We don't have a clear answer. There's rumblings that there may be a new guideline for starting at a higher FiO2, but I don't think we have the definitive data to say for sure we know what that level should be.
Anoop, thanks so much. This has been such a short but great conversation. We're really happy to have you, and I'm sure the audience really appreciates your time. So thanks for being part of our first Global Neonatal Journal Club.
Yeah, thank you so much for having me, Brett. Looking forward to hearing more and learning more from your audience and then these other studies that you're reviewing.
Okay, over to me. So we've got a couple of questions on the Q&A page as well as on the chat. Maybe I'll throw it open first to Shiraz to talk about the difference between the Vent First study that was led by Karen Fairchild, published in 2024, I think, and this study. Shiraz?
Yeah, thanks for the question, Atul. So Vent First was quite similar to the ABC3 trial. Again, similar size, around 500 babies born under 29 weeks gestation in the US, multiple centers, comparing intact cord resuscitation to time-based cord clamping of 30 to 60 seconds again. But the intervention was a little bit different in that it wasn't really that sort of physiological target that determined when the cord was clamped. It was actually for about 120 seconds. So intact cord resuscitation for about 120 seconds. And how that was actually achieved was different at different centers in terms of the platform and the equipment used. But the key finding there again was that there appeared to be no evidence of a difference in the primary outcome of death or any intraventricular hemorrhage between the two intervention groups. They also did an interesting analysis, subgroup analysis based on whether the baby was breathing well or not after birth, and people might want to go in and have a look at that. But the sort of overall finding was, again, no evidence of a difference of intact cord resuscitation versus time-based cord clamping, delayed cord clamping.
Thank you, Shiraz. Maybe we'll open up the questions that the participants or the audience has typed onto the chat pane. First of all, from Shripa from Perth, he's asked whether liberal oxygen saturations are better than lower saturations that's been shown in the adult and pediatric ICU setting. Maybe I could throw that open to Graham.
Well, I think you'd better go on that as well afterwards, Julie.
No, I'm not going to answer that. Graham has to earn his cross, man.
Thanks, Julie, for the world oxygen expert passing it on to a sheep physiologist. But and this is again my own personal experience and also personal opinion, that I think we should be starting in much higher oxygen. I think there's a lot of physiological reasons why we should do that at the start of resuscitation. I think we got to remember that as soon as the baby comes out, its lungs are filled with fluid. Part of resuscitation is trying to push that fluid out and aerate the lung. So certainly within the first couple of minutes, you're only going to have a very small area for gas exchange. So the higher oxygen concentration you've got, the better chance you have of obtaining a higher oxygen saturation systemically. And I think the critical enemy for all neonatologists is hypoxia. The minute the baby becomes hypoxic, it will stop breathing, it will close its glottis, and it makes any kind of non-invasive respiratory support very difficult to obtain. So preventing hypoxia, the best way to do that is by using high oxygen. And I think Julie's trial showed that potentially 60% was not enough in that population. Maybe we could have gone more. And that's what's really exciting about this trial. The thing I want to really also point out is all the trials we looked at today, the control group is not a standard care group. It's almost a medium deferred group or delayed cord clamping group. And all the benefits previously have been compared to an immediate cord clamping group. So again, we're not comparing physiological-based cord clamping to current standard of care. We're actually comparing physiological-based cord clamping or resuscitation on the cord with a deferred cord clamping group. So those differences may not be as obvious as would be compared to the original studies. It also makes it very hard to change the guidelines when no one's actually comparing to the current guideline.
Julie, can I interview you for a second? Are you allowed to just briefly tell us about Torpedo 3060 and what you found, or is that a secret?
Oh, no, not a secret anymore, Brett. It was presented at PAS in Honolulu. So we settled on the low level of 30% and a high level of 60% because they were part of the guidelines at that time. As you know, the history of Torpedo is that in the first version, very few people were willing to join the study because everyone was scared of 100% oxygen. We couldn't get it past ethics and we couldn't get clinician buy-in. So as you know, the first study was truncated at only 15% of its target recruitment. And we had to look at evidence synthesis and other studies to help give us the evidence to go on to the next step. I think all these studies are taking a lot of our time and effort, and we need to join together to look at larger numbers to have meaningful clinical outcomes. So Torpedo 3060 is a trial of less than 29 weekers that were initially resuscitated with either initial 30% or 60% FiO2 and adjusted to target a common SpO2 of 80% by 5 minutes. What we found was no difference in the primary outcome of death and brain injury from either of the arms, but the babies that were started on the lower FiO2 arm, the 30% arm, had lower SpO2s, lower heart rates, and a higher need for delivery room interventions like cardiac massage, adrenaline, and other more intensive support in the delivery room. So there is a noise that maybe starting off low may not be the best for these preterm babies, but we don't know how high we should go. And like Brett says, what we're doing now is not looking at what we did before. So before 2006, we were giving everyone 100% oxygen and not monitoring. We don't have a comparator arm anymore. So yes, that hopefully the Torpedo study would be out soon, but I think we need to plan the next steps and look at multiple interventions for this primary outcome of death in preterm babies. I've lost my train of questions.
I might be able to step in. There's a few.
Thank you. I think that's
Omar
one
Cameron
from
and Dominic Wilkinson are online from London and Oxford. So hi to Omar and Dominic. And they've both asked in a different way, about antenatal consent and the issues that poses for particularly delivery room trials, which is a huge issue for us all. June, you've run delivery room trials, Shiraz. In the clinical setting, it's really tricky, isn't it? And what we're seeing over and over again is that you really cannot get a representative sample of mothers or babies included into your randomised trial when it's an emergency and you still need antenatal consent. I think Shiraz, you showed that really well, that the proportions of actually eligible infants or mothers that were enrolled in these trials were relatively low. And it's really common to see less than 50% of eligible babies, for example, enrolled. This is a big problem. And I know there's people around the world calling for alternative forms of consent, specifically for delivery room, urgent or emergency trials, and that's got a whole lot of ethical issues associated with it. But I agree with them. It's been shown time and again, and most recently, I think there was a paper published from the SAIL trial team, first author Louise Owen, only in the last day or so, showing really nicely that if you use an alternative form of consent, such as deferred or retrospective consent, you can get different results. And that's really scary when you consider that nearly all of our trials don't really enroll a high proportion of eligible babies, especially in the delivery room. And if you think of it that way, just for a second, it makes your mind really freak out when you think that actually we could be getting results that are simply not accurate because we're not getting the sickest, smallest babies enrolled in the trial, or we might be missing a benefit or a risk there. So I'm certainly one who's sold on the idea of alternative consents, but we've got a long way to go still in certain parts of the world to convince the community that that's an ethical thing to do. June, would you like to give us any of your experiences with delivery room trials? Have you used antenatal consent or other forms of consent, and what issues or have you found with that?
Right. So my own pilot trial using the calorimetric entitled CO2 in the delivery room, we couldn't get past deferred nor waiver consent either, even though actually many of in our audience in the units have been adapted this into the practice using the PDCAP as part of the MAS. So even for such minimal risk studies in certain institutions, and Julie can tell you that initially when we was invited to be part of Torpedo, they have issues, right, with us getting the 100% arm. So antenatal consent, I think depends on different parts of the world. I'm really envious of our Australian colleagues because I see so many trials coming out that, many of the units get deferred consent as well as Canadian and all that. So I truly believe that it doesn't really present the real world setting. The results that we read from trials like ABC3 trials where 99% to 100% antenatal consent, regardless of what the results are, it doesn't apply to what we see every day. The precipitous deliveries, the emergency C-sections. We are clinicians. We can't really interpret that to what we see on an everyday basis?
So I can say something about that. So the torpedo was 80% recruited from consent waiver and 20% from informed consent. And in our analysis of the babies after that, the consent waiver babies were not much different from the informed consent. In Torpedo 1, we only recruited the bestest babies, right? Because it was all informed consent. We had to wait 6 hours between the time the mom hit the hospital to approaching the mom. It's a very difficult process. And we were highly supported by parents groups like Melinda Cruz from Miracle Babies to help us obtain waiver of consent. And we've done quite a bit of work, I guess, with Anoop and all the other resuscitation, researchers to look into how parents view this informed process. And I think we'll be surprised to see that it's more easily acceptable for them than we would imagine. And I think that's the way forward. We cannot afford to waste more time retarding our resuscitation studies with consent processes that are not feasible in real life. So there's a question here for Shiraz, SpO2 targets. I can't find it. Hang on, where is it? Or has it been answered? No. So I might draw on June again because Azana's asked a question about SpO2 targets for preterm infants based on the gestation or physiologically based targets. Is SpO2 as an index alone sufficient as an indicator? What happens in, many parts of Asia where you do not have the oximeters or even blenders? What would you do?
Well, we're lucky enough to be in an institution where we do have blenders, but even in the same setting, we do have private folks that don't have blenders and don't use blenders. I think SpO2, to achieve the target SpO2, like previously said, is not just by provision of oxygen. I think there are also other parts of ventilating parameters that can help us get to the SpO2 target. For example, monitoring if we're actually providing sufficient ventilations, using other markers, whether there is a good tidal volume, good CO2 feedback. So I think it's part of something that is important, but we do have to look at others parameters as well. I don't know if I answered that question.
No. I guess what I'm saying is that we are concerned about the definition of hypoxia in the delivery room. But what if you don't have equipment to tell you that the baby is hypoxic or hyperoxic? What would you be looking at?
The baby.
Yeah, I guess.
Absolutely. Yeah.
Yeah.
I remember when I started Torpedo, one of the Malaysian neonatologists said to me, "Oh, Julie, those air babies don't look that great." Look, I guess it's an important thing, right? Yeah.
I guess now we're so fixed. We're so fixed with the SpO target because of some studies showing that the color and appearance do not necessarily match with SpO2. But you're right. When our hands are tied, we don't have the technology. Looking at clinical examination would be the next best.
Thanks, June. There was a couple of questions coming through about giving high amounts of oxygen to these babies during delayed cord clamping. It was something that I posed to Anoop. Is it safe to give whatever, 100%, 60%, 90% oxygen during delayed cord clamping? He went some way to answering that, but I don't know, Graham, Shiraz, or Julie, whether you wanted to have some input to that. Do you think that we're causing any potential damage in that 1 to 2 to 3 minutes of delayed cord clamping by giving, for example, extremely preterm babies high amounts of oxygen while they're on the cord?
I think there's really good preclinical data now. Sorry, that's my phone ringing, of course, at the wrong time. There's some really nice preclinical data, including one that we published recently in pediatric research, which showed that providing high oxygen whilst in this case, preterm lamb is attached to the cord, the placenta actually does remove a lot of that oxygen. So it prevents the really, really high cerebral and systemic oxygen that you would normally get if you were providing that high oxygen after the umbilical cord was clamped. I think the proviso for all these studies is that it's very brief, short-term oxygen. So ANOOPS was only a minute or so. We did prolonged 100%, so for 10 minutes, and certainly 10 minutes of oxygen on the cord compared to 10 minutes of oxygen, 100% oxygen off the cord, was no different in terms of lung inflammation and injury. So they were both equally as injurious. So prolonged high oxygen is not a good idea, but brief oxygen, high oxygen is probably okay whilst it's still attached to the umbilical cord.
Yeah, thanks, Graham. And, that's what Anoop seemed to be saying as well, that he didn't think there was any concerns about that. We had the same thoughts when we were thinking about giving oxygen to babies during endotracheal intubation and whether such a brief period could cause any damage, and we thought probably not. And when you think that in the NICU, at least, people are turning the oxygen up and down for various things all the time, it seems unlikely that a short procedure in the NICU, or in this case, a minute or two on the cord, could be damaging. But it's good to hear you talk us through the preclinical data on that. What other questions have we got coming through, Julie or Shiraz?
Could I ask you, Brett, as our trialist, our adaptive trialist, how would you plan the next study?
Yeah, good question. Well, the trials that we've heard about today, you could argue whether they've chosen the best primary outcomes or not, and there's always a balance between feasibility and short-term physiological outcomes and a much greater sample size with thousands of babies and important clinical outcomes, and which one's more likely to be affected by something that only goes for a few seconds or a few minutes in the delivery room. You've got to weigh all of these things up, and so it's not easy to do trials like this. We've been looking at some different types of primary outcomes, specifically for an adaptive platform trial called Platypus that we're planning in this part of the world. And we've come up with an ordinal outcome. So this is like a ranking, if you like, of things that can happen to preterm babies, bad things that can happen from nothing all the way through to death, and using different sorts of analyses to look at that Bayesian analysis. I know Anoop and others have been looking at the desirability of outcome ranking, or door scale, and as another option. And I do think that we do have to come up with something that parents and individuals who've been affected tell us is important, and help us with the rankings of those things to really make sure that our outcomes are clinically important and important to the community. It's even still, you've still got the issue of, do they predict longer term outcomes, which really matter? What about childhood outcomes? And feasibility always comes into it. But I do think we have to move away from dichotomous and probably even dichotomous composite outcomes that have their own issues. And something that we're all working through and not quite sure we've got the right answer yet. But certainly the ordinal outcome we're proposing for Platypus is a 15-level scale that might go some way to doing that.
I think I'm a bit of a noob at this platform, but there is a hand up on the attendee list, and I can't seem to find who it belongs to.
I'm not sure they can go live, so I think I'll
okay, there's a hand up. All right. Okay, so apologies if we miss you, whoever it is with the hand up.
Shiraz has got one. There you go, Shiraz.
I'll put a hand up just to say,
maybe it's you. Yeah.
There was a really cool question about, well, what about term babies here? Does intact cord resuscitation, would that potentially help them? Do they have more reserve than preterm babies? And just to sort of highlight that here we're talking about trials in well-resourced settings, but there have been a couple of two really good trials in term babies who needed resuscitation in India and in Nepal, and I put them in the chat in the answered questions there. Particularly Reina et al. 2023 term babies where intact cord resuscitation was found to improve APGAR scores. And it may be that in lower resource settings, these term babies are born in slightly worse condition, if you like, a bit more perinatal hypoxic ischemia on average, and they may well benefit from intact cord resuscitation. So that's just something to look at. But as far as I'm aware, there haven't been significant trials of preterm babies receiving intact cord resuscitation in other settings.
Thanks, Shiraz. I see that, we've gone, time flies, doesn't it? That's over an hour and a half of chatting and Journal Club. The numbers are starting to dwindle online as people either head off to their ward rounds in the morning or need to go to dinner, one or the other. It's dinner time over here. So we'll wrap it up now. I'd like to thank the co-hosts for tonight, Julie and Shiraz, and our wonderful experts, Graham and June, for being here. Thank you, everyone online. We peaked at about 240 of you online of the 900 and something people that registered. So I'm sure some of those other people will be watching this back online shortly. So thanks for that. Thanks to Mercy Perinatal, to Stephen Tong and Sue Walker, the bosses of Mercy Perinatal. Stephen's just sitting next to me, for all their support. And also sitting next to me, you can't quite see her, is Bella Preston, who's done all of the work behind this, the graphics, the organisation, the tech, the advertising, everything. So thank you very, very much to Bella. We are planning our next Global Neonatal Journal Club already in the next month or two, and you'll hear about that, no doubt. Feel free to let us know any suggestions of important papers or topics you think that we should be covering. We will be sending out surveys to you all, as well as certificates of attendance that you can use for your CME, and also the link to the recording, which we'll also make freely available on social media and the website as well. A quick advertisement for those interested in longer-term outcomes of prematurity. Mercy is hosting a twilight session in a week's time, Wednesday the 27th, on cerebral palsy with some of the world experts on cerebral palsy detection and treatment. So that will be very interesting for some of you. We're going to go off and have some dinner ourselves and debrief about what went well and what didn't. So thanks for your feedback, and we'll see you next time. Bye for now.